I will now turn the webinar over to our presenter. Dr. Margaret Bell is joining us today from the VA. She is the Director for Education and Training with the National Military Sexual Trauma Support Team. Thank you for Dr. Bell presenting today and being part of the Joining Forces initiative.
Sure, very glad to take over at this point. I am so honored, really, to be invited to be a part of such an important event, particularly because it is part of the larger efforts that your organization is making to make sure that our veterans get the help and the support that they need after they leave the military. And as a VA staff member, I, of course, live and breathe these issues every day, which makes it even that much more rewarding, I think, to know that there are those of you out there that are really doing your best to make sure that wherever veterans are getting their care, whether it's through the VA or somewhere out in the community, that they're going to be getting care that's sensitive to their unique needs and that really is addressing the problems that they're presenting with. And at the VA, as Marcy mentioned, I'm the Director of Education and Training for a national team that the VA has established called the National Military Sexual Trauma Support Team. And we do a lot of national education and training and outreach events related to military sexual trauma, among other things. And so that makes me particularly pleased to be here today to have this slot dedicated to issues related to military sexual trauma. Really glad to capitalize on the opportunity to get the word out there about this issue, its relevance to medical providers in particular, and really appreciate all of you who have dialed in today to spend the next hour thinking about these issues. So with that, I will remind myself how to advance the slides. There we go. So we should, of course, start by talking about what it is that we're talking about, cover some definitions. And to that end, when I use the term military sexual trauma, what I'm referring to is sexual assault or repeated threatening sexual harassment that occurred during a veteran's military service. The term MST, or military sexual trauma, is not one that you will typically hear used in the Department of Defense for folks who are still on active duty or in the reserves. It's a VA-specific term. And one thing to note about it is that it explicitly links and encompasses both sexual assault and sexual harassment. This is really coming from a recognition that the military is, of course, a workplace, and so sexual assault that occurs in the military really can be best understood with a frame of sexual harassment as being part of a larger continuum of negative sexually related experiences that someone might have in the context of their workplace. MST could be a single event for a veteran or a service member. It could be something repeated that plays out over time, can occur on or off base. While a veteran was on or off duty, the location of where the event or events occurred does not matter in terms of whether it counts as MST. And likewise, the perpetrator's identity also does not matter. So it could be a civilian, could be a fellow service member, could be someone higher in the chain of command, someone who's a peer or lower in the chain of command, even an intimate partner. According to the definition that VA is given by federal law of what constitutes military sexual trauma, all of those types of experiences are going to fit under that umbrella. And I keep talking about experiences of MST, and so it's a good reminder to me to point out that the obvious, that we're really talking about experiences here. MST is an experience. It's not a diagnosis. Sometimes people get a little tripped up by that, but I think it's good to point out early on that we're not expecting that people will have a specific set of difficulties after experiencing MST or react in a given way that's predictable. And of course, we'll talk more about that in a minute. goodness. There we go. So to make this a little bit more concrete, when we're talking about MST, we're really talking about any sort of sexual activity in which someone is involved against his or her will. And there are a lot of ways in which non-consent can happen. You know, it's not always the stereotype of someone being physically overpowered, although of course that is sometimes what happens. It's also times when someone is unable to consent to sexual activities, so they may be intoxicated, for example, or times when someone is pressured or coerced into sexual activities. So it may be that the coercion is occurring via threats of more dangerous duty assignments if the service member does not comply, or with promises of positive performance evaluations if they comply, those sorts of things. In terms of the specific behaviors that we're thinking about, we are talking about things like remarks about a person's body or sexual activities, threatening and unwelcome sexual advances, you know, asking someone to sleep with you repeatedly after you've made it clear that that's not of interest, touching or grabbing, all the way to obviously including things like oral sex, anal sex, penetration, or sexual intercourse. And it's also incumbent upon me to point out early on that, of course, compliance does not mean consent. There are many reasons why a victim might choose in the moment of experiencing MST to comply. Again, you know, there may be threats of consequences if they don't. They may feel physically threatened. They may feel that it is the lesser of two evils that is confronting them, and or may really reflect the realities of being in a hierarchy or an environment where choices may be limited more generally. So need to keep that in mind as we're thinking about service members' experiences as well. So you folks all dialed into this webinar, so obviously you had some personal interest in this topic or otherwise thought that it was relevant for your practice. But do want to spend a moment talking about why have a session on MST for medical providers. You know, we think about typically the mental health impact of an experience like sexual trauma, and certainly that is often the biggest portion of difficulties that we're helping veterans or service members address. And to the extent that you may be working with someone whose difficulties do lie solely in the mental health realm, there certainly still is a role for you there in terms of helping connect them with whatever help they might need to recover. But also, as we'll talk about a little bit later, there is a link and an association between military sexual trauma and physical health problems and medical concerns. So certainly that in and of itself places it squarely within the realm of topics that should be on your mind. Another reason that I think it's important for medical providers to know more about MST is that it very often impacts the process of care provision to the veteran that you're working with. And I should mention, I'm going to fall into the default of using the language veterans just because I'm so used to working with veterans specifically on a daily basis. But of course this would apply to service members as well. And so, you know, can very much impact the process of care in working with veterans, in that an MST history often will affect the way that patients react to procedures and exams, and perhaps even to their very relationship with you as a healthcare provider. So oftentimes there are these underlying trauma-related dynamics that are contributing to some of your interactions in the room or some of the reactions that you might be seeing. And so having some insight into that and being aware of what might be contributing to what you're seeing is, of course, really valuable for both you and the patient. It's going to help make sure that you're meeting their specific healthcare needs. It's going to help you make sure you're adapting your care to be sensitive to, you know, kind of how to provide that care in a way that is going to be sensitive to their needs. And then, of course, on your end, really going to help, I think, oftentimes streamline interactions, help engage patients in care in a different and perhaps deeper way. And then also being sensitive to some of the reactions we're going to talk about that might come to your attention can in and of itself be reparative for a victim. And so if I leave you with one message today, I really hope it's that you don't need to be a mental health provider in order to help veterans in their recovery from experiences of MST. There are most certainly things that you can do that will not only improve their medical care, their medical outcomes, but also really in the long run help with any mental health difficulties or other struggles they're having as well. So to that end, what I had on the agenda for today was to start by talking about what exactly the problem is that we're talking about. So talk a little bit about prevalence and the impact of MST on veterans, and then really get into the meat of it in terms of what you can do to take that into account and adapt the care that you're providing. But of course, we only have 1 hour together today, so that there's going to be much that is left unsaid. So I definitely want to make sure I leave you with ways to learn more after we sign off for today, including information about resources that are out there, particularly in terms of VA services related to MST. And I want to say up front, just as a clarification, that there are certainly ways in which the experience of military sexual trauma is different from the experience of other types of traumas, combat, car experiences, intimate partner violence, natural disaster, those sorts of things. And I'm certainly going to highlight those differences as I go along. But I also want to mention right up front that there are ways in which the experience of MST is similar and overlaps with the experience that someone might have as a result of some other form of trauma. So as we're going, you'll probably hear some things that maybe ring a bell and maybe tap into things you've heard before about working with patients who've experienced psychological trauma, and that's great. Please feel free to connect that existing body of information you've already got with what I'm speaking about today. But along the way, you're going to be hearing things kind of that are falling in each of these 3 bubbles that I have up on the screen about trauma more generally, sexual trauma more generally, and then also, of course, specific to sexual trauma in the military context. So again, turning to the problem, one question people have early on and that we should talk about is how common is MST? And unfortunately, it's an issue that you may run into more than you think. As with sexual trauma more generally, we, I think, have to realistically expect that any numbers that we're going to be providing are going to be an underestimate, an underreport. But what I can give you are the data that we have in VA from our universal screening program, where every veteran who comes in for health care is asked whether he or she experienced MST. And those data show us that about 1 in 5 women and about 1 in 100 men that are seen for VA health care do tell us that they experienced MST during their service. And those rates are comparable both for the general population of veterans that we see in VA as well as for the rates among more recently discharged veterans who are coming from Iraq or Afghanistan. So, we're hearing a lot more about the issue of MST in the media these days, but it is unfortunately an issue that has been with us for a much longer time. We have veterans from all eras of service that we see having had these experiences. So those data, of course, are only speaking to the veterans that have chosen to come to VA. Hard to know how generalizable that is to the population of veterans more generally. And then, of course, don't also tell us what % of those veterans are actually currently having significant struggles related to their experiences of MST or need or want treatment. But what they do tell us is that if we look at the absolute numbers of men and women who are screening positive for MST, they're about comparable. So although the rates are much higher among women, there are simply many more men than women in the military. And so the absolute numbers do work out to be about comparable, meaning that it really is an issue that you should have on your radar for both male and female veterans that you may be working with. Second part of, kind of understanding more what the problem is that we're facing is talking about the impact of these experiences. And, people are remarkably resilient after experiencing trauma. And not surprising, we see a similar pattern with our veterans. There is no one way that veterans are going to respond to experiences of MST, much like responding to any other form of trauma. But our veterans are often incredibly strong and incredibly resourceful and resilient in terms of coping well after incredibly distressing and terrible experiences like MST, and at times will recover quite well on their own without professional help. There are some veterans that continue to have difficulties at particular times or strong reactions to certain situations, for example, during medical encounters, as we'll talk about, but otherwise are doing relatively well and are functioning at a high level. And then, of course, a third group of veterans that really are experiencing more profound or longer-term problems. This is particularly likely for veterans who have childhood experiences of trauma and or other traumatic experiences during their service and or post-military traumatic experiences. Kind of the layering effect of trauma just increases the health burden. And then also in working with veterans of Iraq or Afghanistan, their experiences of MST may be relatively recent, and so when they present in your office, their distress may be more acute and kind of flagrant than you might see with other veterans. So, the focus today, of course, is on veterans that are having at least some problems, if not more generally, at least, kind of when they show up in your office and are having encounters with medical-related encounters. But, so, that's what we're going to be talking most about is the veterans who are struggling. But I do think it's important to keep this larger frame in mind so that we're reminded that we should not assume that everyone has the same needs related to their experiences of MST. Most commonly, it is, of course, the mental health-related issues that we think about after experiences of trauma. And the VA data that we have show that the mental health diagnoses that are most commonly associated with MST are PTSD, not surprisingly, that is the top diagnosis, but also things like depressive disorders, anxiety disorders, bipolar disorders, substance use disorders, and schizophrenia and psychoses. Among sexual trauma survivors more generally, some other common diagnoses include eating disorders, dissociative disorders, and somatization disorder. And in terms of what that might look like in terms of the actual struggles that you're seeing in the veterans that you're working with, it will look like things like extremes of emotion and emotional lability, or opposite, emotional disengagement or flatness. May also see some difficulties with attention, concentration, and memory. Certainly the classic re-experiencing symptoms like nightmares, flashbacks, strong reactions to reminders of their traumatic experiences. Veterans may present as being jumpy or on edge, kind of have an exaggerated startle response, trouble sleeping, suicidal thoughts or behavior, self-harm behaviors like cutting or burning, drinking and drug use, disordered eating like restriction or food restriction or binging, dissociation, sexual dysfunction, and so on. Of course, this isn't an exhaustive list. So given the significant health impact of experiencing MST, it's not surprising that we also see difficulties in some core areas of functioning. Things like getting and keeping a job, or attending school, maintaining healthy relationships, and being able to connect with others in a meaningful way. May also see difficulties with parenting, with identity and sense of self, and then also certainly at times spirituality crises or issues. We also know that rates of military sexual trauma are higher among homeless veterans, and that for many of those veterans, MST was certainly a contributor to them becoming homeless. Maybe less known or certainly less thought about in many quarters, but there is a link between military sexual trauma and physical health and medical conditions, as I mentioned earlier. So again, the VA data show us that the physical health diagnoses that we see associated with MST, the top ones are liver disease, chronic pulmonary disease, chronic pain issues, GI problems, gynecological problems, and then in women, obesity and weight loss and hypothyroidism, and among men, AIDS. So, obviously, we know much more, in recent years, there's been such an incredible attention to the mind-body connection, and we know a lot about how mental health problems in general will definitely affect someone's physical health. So it's important to remember that as a backdrop, I think, for any conversation where we're talking about mechanisms for the link that I just described. But in terms of, as we start thinking about what might be driving that link between MST and physical health problems, two options often come to mind quickly for people. One is that veterans who experienced MST may perhaps simply be more inclined to speak up or seek help or, bring things up that leads them to receive these diagnoses. Or that it may be a situation where perhaps MST survivors are more likely to translate their mental health symptoms into physical health problems. So, those are good thoughts, but those mechanisms really don't explain why we see higher rates of actual diagnoses of medical conditions among veterans who experienced MST. So they can't be the biggest explanatory factor for that link. Some more likely suspects I've got listed at the bottom of the slide there, the first being direct health effects. So if, during her experiences of sexual trauma, Kelly is knocked to the ground and kicked in the teeth, perhaps has some vaginal or rectal tearing, that certainly is going to be a direct health effect of having experienced MST. Indirect mechanisms, if Scott smokes or drinks to manage his symptoms related to his experiences of MST, or engages in risky sexual behavior after experiencing MST, those could be mechanisms by which he might go on to develop some medical problems related to MST. And then finally, we know that psychological trauma changes our physiology. It changes our hormones, our neuroendocrine, leads to neuroendocrine changes. And those changes can, of course, underpin or contribute to the medical problems that we see as well. So I just finished reviewing the impact of MST in a somewhat medical model-bound way. So I want to step back a little bit and talk about some of the ways in which the experience of MST may change how a veteran really interacts with the world. I encourage you to think about what you've seen, what you've noticed in the veterans you've worked with who've experienced MST. But I want to to frame that discussion, want to start with a few examples of situations I'm familiar with coming up with medical providers in particular. So, for example, we have David. So, when you discuss the need for a colonoscopy, David becomes very physically agitated and withdrawn. He starts downplaying his symptoms and says he's just not sure he has time for all these appointments right now. Or perhaps you've met Jean, who always jumps a little when you touch her, and she has an elevated heart rate throughout your appointment. She seems to have a particularly hard time in the small exam rooms at your facility. Then there's Sean, who avoids any preventive care and only contacts your office when a problem has reached crisis levels. Tamika has managed to avoid a gynecological exam for the past 5 years. When you finally convince her to have one, she cancels the appointment at the last minute and never comes back. Andre's anxiety is so high during routine dental exams that he needs to be sedated, and he insists on having a female dentist. During appointments, Joanne will sometimes burst into tears or abruptly become angry. Other times she seems to check out and stare off into space. And of course, this is, I put others up there, again, to encourage you to think about what you have noticed with the folks that you've worked with. But I think when we look at these scenarios, in each one there's some seemingly odd behavior or something that's really reflecting a different way of interacting with medical care or really interfacing with the world more generally. Something that leaves us asking what might be going on that is driving the way this is playing out. So let's talk about that next. And to do that, I want to step back a little bit and examine the big picture impact of trauma in general. So not just MST, but trauma in general. And if we look at the Diagnostic and Statistical Manual of Mental Disorders, we're using the 5th edition now, the definition of trauma really focuses on the event, so exposure to actual or threatened death, serious injury, or sexual violence. And so that's a key component that's important for us to think about. But I think we should also pair that with perhaps thinking about it in terms of a parallel to physical trauma, which I found one definition that described it as a serious injury or shock to the body. So I think we can think about psychological trauma as being something so shocking or unexpected or terrible that it's truly life-changing for someone. Most of us walk around each day somewhat shielded from the most awful and shocking things that happen in life. And trauma essentially pulls back that veil for us and provides this really shocking, abrupt reminder that we are really profoundly limited in what we're able to control in the course of our lives. Trauma also often involves an exceptionally strong emotional and physiological reaction at the time of the event. So really creates this novel experience for someone where your normal coping strategies are really pretty ineffective. Your regulatory systems are simply overwhelmed by what is happening. And so in essence, what a psychological trauma does is pull the rug out from underneath you. Really drops you in this strange land where everything has changed and doesn't make sense according to what you thought before, prior to that event. And yet, that's trauma in general, but there's some evidence to suggest that sexual trauma and military sexual trauma specifically are particularly toxic for veterans. So again, PTSD is certainly not the only condition associated with MST or sexual assault, but we have some research suggesting that sexual assault is among the traumatic stressors most likely to lead to PTSD, even more so than combat. And then also some research suggesting that there may be an additional burden associated with military sexual trauma, with MST being with military sexual trauma relative to civilian sexual trauma, with MST being associated with more mental and physical health concerns compared to civilian sexual assault, as well as a stronger association with PTSD and other mental health conditions. So, of course, you know, we wonder what's going on there, and that's a crucial next step for research to continue to explore. But what I have on this slide here are just some factors for us to think about as we try and understand why MST in particular might be such a toxic experience for someone. Some of these are unique to MST, others generalize to perhaps any other traumatic experience someone might have during their military service, but I will go through them relatively quickly, just knowing that, again, we only have an hour here together. So the first is that MST is an interpersonal trauma. It's something that's perpetrated by another human being, frequently a friend, an intimate partner, or some other trusted individual. And because of that, it has some pretty profound implications for a veteran's beliefs about relationships, trust, and perhaps even themselves. And then the military context adds another layer to that. You know, it's a situation where you're literally trusting others with your life, both out of necessity and out of training. Also a context where there's a strong emphasis on loyalty and camaraderie. And so really, again, kind of contributes to the sense that the rug has been pulled out from underneath you. For many veterans, MST may have been ongoing over time. Because of the context, it may not be possible for someone to get away. You know, you're living, socializing, working with the same group of people. And so that can, you know, create the potential for there to be ongoing re-victimization from the same perpetrator or perhaps from the perpetrator's friends. And can also, for the veteran, increase the sense of feeling trapped and of being helpless, which we know is a component of trauma that is associated with even worse outcomes when someone has this kind of ongoing sense of being helpless and trapped. A key thing that comes up with veterans who experienced MST is often that they are pretty lacking in social support, people to turn to for help, for support. At the time of their experiences, they may be deployed or otherwise far from their friends or family. Even when they come home, they may hear from others that their experiences aren't, quote, real trauma or aren't legitimate or, you know, not the same as combat trauma. And so this can really contribute to veterans being reluctant to seek out support, and of course mean that when they do reach out for help, they might not necessarily get it, whether that's from formal or from informal sources. And this lack of social support factor is a huge one. We know that the most consistent findings in research are that social support is the strongest and best predictor of recovery after experiencing trauma. So the fact that MST survivors often lack it is really a profound problem. Another variable is that veterans who experience MST are often young at the time of their experiences. They don't have a fully developed repertoire of coping strategies, and so may turn to things that work in the short term but cause longer term problems for them. So things like cutting, drinking, maybe aggressive behavior. Another factor is that, you know, there are certain values and beliefs that are promoted by the military and that support the military's mission that are very adaptive in that context, but then may complicate things when it comes time for recovery from an experience like MST. So one example of that is the priority on strength and self-sufficiency that exists in the military. Weakness is really viewed as a failing. And of course, the experience of victimization is completely at odds with that. And so it can be very difficult for service members and veterans to accept or to understand how this experience of MST has happened to them, particularly to the extent that a core part of their identity is really wrapped up in this idea of being strong and of, that kind of being the most important thing in your identity. So oftentimes we will see veterans who are very reluctant to acknowledge that this has had a significant impact upon them, have significant feelings of self-blame, all of which, of course, complicate their ability to recover. MST sexual trauma has a meaning and a tone to it that's different from other traumas, a societal tone. It involves topics that make people uncomfortable. We're talking about sexual behavior. It plays into biases like just world biases, where we tend to be inclined to blame victims for what happened to them. Bad things only happen to bad people, that sort of way of thinking. And in the military context, there's this added layer that it's not what people expect to hear from a veteran. It's not valorous. It's not what they expect to hear about combat experiences, and so often just don't even know what to do with it when someone discloses that they've had this experience. And because there is this tone to the experience of sexual trauma, victims often, unfortunately, will come to conclusions that kind of draw conclusions about what it must mean about them as opposed to about the experience. So it means that they are dirty, that they wanted it to happen, that they asked for this to happen. It's their fault, those sorts of things. And then finally, MST certainly is going to intersect with any other experiences of trauma that a veteran may have. We know that the lifetime experiences of trauma are exceptionally high among veterans, concurrent exposure to combat certainly, and we know that the effects of trauma are dose specific. So the more traumas or the worse traumas you experience, the worse the outcome. So again, those are some of the reasons why I think we often see that the experience of MST can be even more strongly impactful upon veterans than other experiences of trauma. So I'm looking at the clock and want to make sure that I get to the meat of things that are going to help you in your work with veterans. So I'm going to skip over a few of these slides. With going to the take-home point that actually, I'll back up a little just to cover this one. So if you think about those factors, you can really imagine that it leaves survivors in a number of binds. Whether to trust someone when you know that even friends and family can be untrustworthy, whether to trust yourself when you know that there can be some pretty profound consequences to being wrong, whether to get your needs for connecting with other human beings met, even when you know how severely others could hurt you, those sorts of things. And, those are not reconcilable dilemmas. They're balancing acts. And because they are so difficult, it often can result in some of the confusing behavior that we saw in those vignettes that I put up a little bit. Veterans themselves sometimes feel like they're going crazy. But what I'd like to suggest is that there's another frame to it. It's not that veterans are going crazy. It's not that they're behaving in bizarre or unreasonable ways. It's that their behavior is really reflecting an adaptation to a context that is difficult to manage. Certainly the experience at the time of the trauma, but also since then in terms of the overwhelming emotional reactions they may be having, the changes to their physiology, just the sheer confusion of what this means about the world and about their experiences. And so if you look at the things that you're seeing with this frame, you can often see that there's a self-protective function to it. So, if we reflect back on the vignettes that I gave you, again, with looking at the clock, I'm not going to go through this in as much depth as I would like, but just to point out that the themes that you see in those vignettes, all of them can be parsed in this way to really look for this logic. So in the scene where David is avoiding the colonoscopy, or, Tamika is leaves you after canceling her gynecological exam. You know, that is really reflecting this reality that those behaviors are going to help them escape from pain or something difficult. At least in the short term. You know, they're not thinking about the long term. But for you as a provider, it may be exceptionally frustrating because you want to get them in, you want them to get the care they need so that they're healthier in the long term. Again, if you think of this with a frame of this is about protecting their sense of self, it's about them feeling more safe, it's about them avoiding something that perhaps would be profoundly difficult for them, it makes a little bit more sense, and hopefully that is maybe something you can hold along with the reaction that you have to really, of course, wanting them to come in. So some other examples up there too. And then, you know, the take-home point that, of course, you know, these are healthy and normal needs that are really driving some of these confusing behaviors we might see. You know, they're about trying to cope, trying to manage symptoms, trying to feel in control, trying to feel safe, trying to find some meaning and comprehension in what's going on. But of course, you know, there are ways to get those needs met in ways that don't interfere with a veteran's health or interfere with them living the kind of life that they want. And so that is, of course, where we come in. So what can you do? First, you know, I want to suggest adding routine screening to your repertoire if you're not already screening for MST. We do in VA. It's certainly a common experience among our veterans with profound implications for their health care and provides a real important context to know for the problems that they're presenting with. You're going to be using the same principles that you would use to screen sensitively for any other form of interpersonal trauma. And, oops, should have gone to the next slide. Same principles as you would to screen for any other form of interpersonal trauma. And don't be afraid to ask. We know from studies that victims tell us that they want to be asked, they think it's important for their providers to know, but that oftentimes it's difficult for them to raise that issue on their own. So you asking can be the first step in getting them the help that they need. Of course, you want to be sensitive to the barriers to disclosure, shame, self-blame, stigma, those sorts of things. You want to, there are different ways to do this, of course, you know, written or screening, but I'm going to focus on in-person disclosure here. And the most important thing is to really establish a climate that is going to promote someone feeling comfortable to speak up. So you want to make sure, you know, you're minimizing your interruptions, it's a private setting, you know, the door is closed, and that you really convey to them that you're listening, that you're there to hear, and really want to know what they have to say. Want to provide a rationale for asking so that it's not a question that's kind of coming out of the blue and is abrupt and they don't understand why you're kind of asking this exceptionally personal question. And then there's some really interesting research showing that sexual harassment victims can have similar levels of difficulties in terms of health, whether or not they label their experiences as sexual harassment. So we don't want to be screening with language like, did you experience sexual harassment, were you raped, were you sexually assaulted? We really want to be focusing more on behaviorally based language. That's what's going to help us identify the folks that are really struggling. And on these slides, I've got some sample language that you can use. The first paragraph here is really setting the tone, explaining to the veteran why you're asking these questions, and then the second paragraph has got some behaviorally based language there. As I mentioned, you know, the rates of childhood and adult sexual trauma are also very high among veterans. So although we are zeroed in on MST today, also want to highlight that it's just generally good practice to ask about civilian experiences of sexual trauma as well. And so it may make sense to do that in combination with asking about MST. And so on the slide, I've provided some sample language that can help you do that as well. And again, I apologize that I'm whipping through these, but I really hope you'll access the copies of the slides afterwards. It's really important for us to think about not only what to do when someone says yes, but also what to do when someone says no. It's possible that it's a genuine no, but we also know that veterans sometimes don't disclose the first time that they're asked. And so we want to make sure we leave the door open for them to disclose at a later date if they feel more comfortable about that. In terms of responding to yes, I think the most important thing to do in that moment is to be human. That's what we hear from the research. That's what we hear from veterans. That's what they are looking for from their provider. And there are studies showing that you can effectively convey compassion and a supportive response in as little as 40 seconds. So really, there are all sorts of time pressures. There's all sorts of things that are going on for you. But I think it is exceptionally important to carve out that time to simply sit and be still and witness that the veteran has shared something exceptionally difficult with you. Of course, monitoring your nonverbal behavior is incredibly important to this, and just generally conveying that attention and being non-judgmental. One, of course, ask some follow-up questions to find out what the current struggles the veteran may be having related to this, learn more about their current needs. And then, of course, while it may make sense for there to be a mental health referral or for you to refer them for other services, it certainly is going to have an impact on your health care, your work with this veteran as well. And so you want to have a frank conversation about whether there are things you should be doing differently, things that are going to be particularly difficult for them, and just generally find out what you need to know as a medical provider. Some language there also about how to offer a referral, including to VA services, which I will fill you in on a little bit more in a second. After someone screens positive, in your ongoing treatment with them, there is, of course, so much more to be said about the issues that you want to keep in mind that might come up with them. But given the range of difficulties I outlined earlier, you want to make sure you're particularly keeping an eye out for them. Don't have time to go into these in depth, but most certainly want to be watching for mental health difficulties, suicidal behavior or thoughts, disordered eating, self-harm, risky behavior, and of course any experiences of re-victimization. In your own work, you also want to be thoughtful about what you might want to do to adapt your behavior to make sure you're being sensitive to the particular difficulties that veteran may be presenting with. And there are some things about the medical setting and the medical provider relationship that can be very difficult for veterans. So it often involves there being a power differential, there being physical pain, there's this, physical exposure of one's body and touching of intimate body parts, and generally times when, as a patient, you feel like you're not necessarily in control of what is happening. And those, of course, are all exceptionally triggering things for a veteran who experienced sexual trauma. Physical exams and medical procedures, of course, are kind of the height of those experiences and can really be particularly difficult for people. The sorts of exams you might imagine would be difficult. None of these are going to be a surprise to you, I think, if you think about it, but ones in particular to keep in mind as ones that you want to do some advanced planning around with the veteran. Fortunately, there are some things you can do to make it easier for the patient. Kind of the general rule of thumb to keep in mind are these items I have here in red. So the more you can do to help restore the patient's sense of control, and the more that you can do to reduce the power differential between you and the patient, the better off this is going to go. So it is, really straightforward things like, have conversations while the patient is dressed, making eye contact, giving the patient as many choices as you possibly can. In terms of exams and procedures, of course, want to think ahead, have a conversation with the veteran about what's going to be the most difficult, brainstorm about what you might do to help address what's going to be difficult. During the exam, there are things you can do, ask permission before touching, keep a running commentary of what you're doing and are about to do so they know what to expect, and of course check in with them and respect whatever reaction the veteran is presenting with. Never ignore or dismiss a request or an expression of distress. That can be incredibly re-traumatizing for someone. There are going to be times when someone has a strong reaction despite your best preparations, and at those times, again, I think it's really about being human, listening empathically, acknowledging the distress. If it's appropriate, apologize, explain the reasoning behind your behavior, and again, return to this frame of really thinking about what extent feelings of helplessness or of vulnerability or of being out of control might be contributing to what's going on. Some suggestions about how to help someone settle down in the moment when they have a reaction. And then certainly also paying attention to your own reactions. As healthcare providers, we have a wonderful desire to help other people and an incredible capacity in that regard. And while that is an incredible gift, it is also something that at times can leave us vulnerable to just the impact that this work can have on us. So it's important for you to seek out your own sources of support and to be attentive to your own stress level, doing what you need to keep yourself grounded so that you can do good work with the veterans that you're working with. Some resources for learning more, really encourage you to check these out if you get a chance. And then just very quickly about VA services, if I could only get one take-home point in related to it, it's that VA provides free care for all physical and mental health conditions related to MST. This is totally independent of the disability claims process. Veterans do not need documentation of their experiences. All they literally need to do is go in and say they had this experience, and they are going to receive this care. There are some veterans who can get the free MST-related care even if they cannot get other VA care, so they should never assume that they are not eligible. The best person for getting hooked up with care to be in touch with is the facility MST coordinator. They can simply call up the medical center and ask to speak to the MST coordinator. Recently returned veterans can also connect with someone called the OEF-OIF-OND coordinator. And certainly more information is available online or through our general information hotline. So I deeply apologize that we're so run up against the hour here, but I'm happy to take whatever questions you have and very much appreciate your partnership in helping our veterans recover from some of these difficult experiences. So thank you.
Thank you, Dr. Bell. Thank you so much for sharing your expertise. We do have a couple questions that came in that Anita will address.
Hello, everyone. The first question, and maybe Dr. Bell, you could go back a couple of slides to the resources for training, because the question is there a way to get more training about this area or experience? So maybe we could just put those up for a minute or two. Yes.
Yeah, I'd really highly suggest checking out this first handbook. It's an excellent resource, very practical information. And then, of course, the informational websites in the middle there. The last links there, these are really amazing websites that the VA has put up. They are videos of veterans sharing their stories of recovery, really talking about their struggles and how they got to a better place with them. And they're incredibly moving and really can give you some great insight into what some of these experiences are like. So I highly recommend you spending some time on the Make the Connection or About Face websites when you get a chance.
Thank you. So there was another question that if MST is a VA term, what is a term more appropriate for active duty service members?
Yeah, so DOD, the Department of Defense, will use the term sexual assault or sexual harassment, or military sexual assault, military sexual harassment.
And that goes back to your comment earlier about it being sort of a workplace orientation.
Right. I do think that contextualizer of adding military on does make a difference. But for example, if you were to go and were interested in learning what the Department of Defense is doing related to these issues, you'd be best off searching for the term sexual assault and sexual harassment.
Thank you. So that sort of leads into the other question that we've had posed today, and the question is, are senior officers and non-commissioned officers being punished for sexual assault, such as a court-martial, instead of just being forced to retire with an honorable discharge? So maybe you could walk us through the consequences if you have some knowledge about that.
Well, so, I'm coming here from the VA, of course, so I'm not in the best position to speak about what the Department of Defense is doing. They do have a website, sapr.mil. It's sapr.mil, as well as one that is myduty.mil, myduty.mil. Where you can find out more information about their current outreach efforts, their current criminal justice-related efforts, their advocacy efforts, but I definitely wouldn't want to presume to speak for them.
Thank you. Are there any other questions? We have just a couple of minutes more, and I would pose this to our attendees. Well, then we will wrap up today's webinar.
Thank you again, Dr. Bell, for joining us today. This was a fantastic webinar. Thank you to all of our participants for joining us today. We encourage you to complete the survey that will follow this webinar to provide feedback. And tomorrow's webinar will focus on recognizing patients who are parents of service members and how unique experiences with this patient population may contribute to their physical and psychological health. So we hope to have you back tomorrow. Thank you.